Hello, this presentation will be on drugs of abuse, major drugs of abuse other than alcohol and nicotine. Part. So what are the major drugs of abuse? You have the opioids, psychostimulants, depressants, psychedelics, dissociative drugs, anabolic steroids, miscellaneous drugs, marijuana, and LSD. So what are the opiate drugs of abuse? The major ones are heroin, oxycodone, meperidine. Most opioids are Schedule 2 now. They used to be Schedule 3s. Patterns of abuse. They usually start out using the drugs for injury if it's legal drugs, and then they become addicted to those. Otherwise, they start out, of course, with the street drugs of heroin. They have subjective and behavioral effects, and they also have their preferred drugs and routes of administration. So with heroin, the greatest use is in the ages 18 to 25. It hits all segments of society. It does not discriminate between the poor and the well-off. First exposure is usually social or for pain management, as I said a little earlier. Subjective and behavioral effects. Moments after IV injection, they have sensations of pleasure, relaxation, warmth, and thirst, which are followed by euphoria. That is one of the issues with the heroin. The high lasts about 45 seconds, and from then on, they are trying to chase that initial high, which of course they can never get again. What we find now, though, is that patients are starting to, or individuals are starting to get clean long enough and then restart, and so they can obtain that high again. They may have, with the initial time, nausea and vomiting, and they may also even experience some dysphoria. Preferred drugs and sites. Opioid of choice for street use is usually the heroin. There's a high lipid solubility, so it has a big affinity. And then the IV route is preferred, but they will also smoke it and inhale it. Next is oxycodone, which is similar to morphine. It's intended as a control release drug, but abusers will crush it so they can snort it, or they dissolve it in water so that they can shoot it up as an IV. An entire dose is absorbed immediately with a high risk of death. Meperidine, healthcare workers often select meperidine. It's highly effective in the oral route, leaves no sign, and it's a minimal effect on smooth muscles, so fewer problems with constipation and urinary retention, and of course in the hospital that would be more accessible. With these meds you can get tolerance with prolonged use, cross tolerance to other opioids, treatment for acute toxicity. There's a triad of symptoms discussed previously, which are the respiratory depression, coma, and the meiosis, which are the pinpoint pupils. And the treatment for that is the Narcan. You may need also IV. How do you go about doing opioid detox? Talked about that also previously. You can use a clonidine-assisted withdrawal, which is a centrally acting alpha-adrenergic antagonist. It's most effective against symptoms related to the autonomic hyperactivity, the nausea, the vomiting, the diarrhea. Provides only modest relief from the muscle aches, restlessness, anxiety, and insomnia, and does nothing for the cravings. So you can have a rapid, when you're detoxing, there can be a rapid withdrawal or ultra rapid withdrawal. If you administer Narcan, you will get an immediate withdrawal. and it'll be very accelerated. That can also be ultra rapid if with the general anesthesia or with Versed. If you do those, they recommend using clonidine for those other symptoms that would come up. Methadone substitution is a long-acting oral opioid. It is very commonly used. Takes approximately 10 days to detox someone. But to have an opioid, to have a methadone withdrawal, you have to go to a methadone clinic. And those are very specialized, regulated clinics. So now what's the newer way to do it is with the buprenorphine, which nurse practitioners can get their X number from their DEA with a 24-hour contact hour training. The buprenorphine will you start it after the patient has begun to detox to avoid putting them into a rapid detox withdrawal. And it prevents symptoms. It prevents the symptoms or really lessens the symptoms. They usually go away once it's started, and it does help with the cravings. So drugs, what do you use for long-term addiction management? You can use the methadone, you can use the buprenorphine, and you can use the naltrexone. The methadone is for maintenance and suppression as it substitutes the buprenorphine for maintenance and detox, and the naltrexone discourages renewed opiate abuse. With the naltrexone, they will not get the effect from their opioids like they did, but it does nothing for the cravings, of course. What is the sequelae of compulsive opioid use? Few direct detrimental effects. Individuals on methadone maintenance can be successfully working and successful socially. When I lived in Nevada, I was at the health department and oversaw the methadone clinic, and we opened at 4 o'clock in the morning at that time, so that working individuals could come in before the health department opened through a side entrance. And there were several prominent business individuals that would come in for their methadone and had been on methadone for years, but this allowed them to continue without possibly being seen going into the clinic. Indirect hazards. You have to watch for septicemia, cellulitis, abscesses, endocarditis, TB, hepatitis, HIV. All of those, of course, from using dirty needles and sharing needles. And then there's always the potential for accidental overdose, especially when they stop for a while and go back to the same dose, they can overdose. If they begin to use the heroin with their methadone or their buprenorphine, they can also go into an overdose potential. General CNS depressants, your barbiturates, your benzos, your alcohol, and other agents are also abused. The barbiturates, the depressive effect is dependent, so it can go from mild sedation to coma and death, similar to the symptoms of alcohol. They're Schedule 2s also, with a high rate of fatality in smaller doses. Secobarbital, it doesn't take very many of those to cause a fatal reaction. There's definitely tolerance, physical dependence, withdrawal when you stop, and acute toxicity, like I said. But the naloxone can reverse the poisoning of opioids. It is not effective for barbiturates, so that is not an effective way to reverse any of the lethal effects. Benzodiazepines, which are Schedule 4, they are definitely safer than the barbiturates. Overdose is rare when they're taken alone and orally, but if they're IV or if they're mixed with alcohol, are Ambien, one of the sleep aids, or with one of the opioid pain relievers, then that is a recipe for fatality. Um, there is tolerance, physical dependence, there is withdrawals. In my practice where I'm at now, when we have patients that are taking high doses of Xanax or high doses of Klonopin that come to us, we do recommend many times that they go inpatient where it's safe to get detoxed off of those medications. Psychostimulants are Schedule 2s, have always been Schedule 2s. There's a high potential for abuse. And these are your methamphetamines and then the illegal cocaine. It stimulates the heart, affects the blood vessels, and the sympathetic nervous system. These drugs, methamphetamines, the dexamphetamines, of course, are you have your legal ones, your Concerta, Ritalin, Adderall for the children for ADHD or adults with ADHD. And we have to be very careful because those medications can be diverted. The biggest diverter is usually the parents. Teenagers, they can divert to their friends. Um, there's high street value for these medications because while it enables the ADHD person to slow down and concentrate and focus better, for someone that does not have ADHD, it acts as speed. So it's basically a legal speed for them. Cocaine, extracted from the coca plant. CNS effects are similar to those of amphetamines. The most common forms used by abusers are cocaine and then crack, and of course crack is um, a cheaper version. So it's cheaper on the street, and it produces a local anesthesia, vasoconstriction, and cardiac stimulation. If these patients have toxicity, with a mild overdose, they're agitated, they're dizzy, blurred vision. With a severe overdose, they have fever, convulsions, they have dysrhythmias, they can have stroke and heart attack. If you get a patient in your practice and they say they had a heart attack at 28, unless they have some kind of congenital problem, you need to ask about their drug use because many times it's based on the fact that they were using cocaine. The treatment is IV benzodiazepine, the nitroprid, we've got bicarb, aspirin, and then we may need external cooling. For the chronically toxic patient, you have intranasally, you're going to have atrophy of the nasal mucosa and loss of sense of smell because they're snorting, a lot of nosebleeds, so you'll get that necrosis and perforation, injury to the lungs if they're smoking it, and definitely issues, um, behavioral or neural problems with the infants, and physical dependence from that long-term use. One.